Welcome to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from across the schools and departments of the University of Cambridge, reflecting the pioneering work and diverse interests of members of Cambridge Neuroscience. Today we welcome Professor Topun Austin, Consultant Neonatologist at the Department of Paediatrics here at the University of Cambridge and Addenbrooke's Hospital. Topun also leads the Evelyn Perinatal Imaging Centre based at the Rosie Hospital here in Cambridge. He will be joined today by Dr. Sarah Lloyd Fox, Affiliated Lecturer at the Department of Psychology at the University of Cambridge and also Research Fellow at the Centre for Brain and Cognitive Development at Birkbeck, London, where she specialises in developmental neuroscience. Welcome to you both.
Well, look, thank you very much. I'm going to say for the invitation, although I did slightly muscle my way into this series because I sort of wanted to make sure that the fetus does get a look in. And I'm a neonatologist, as you say, from the Rosie, a baby doctor. I'm also a sort of like closet developmental psychologist. I'm fascinated by the developing brain, and I've known Sarah for many years, and I'm delighted to have collaborated with her on a couple of projects, and especially this one. I'm going to start, if I can start, my mouse working. I want to start this talk in February when the WHO declared an outbreak of a relatively unknown virus and a public health emergency of international concern. But this was not February 2020, it's February 2016. And the virus was not SARS-CoV, but a flavivirus called Zika. It's spread by mosquitoes and very similar to a virus causing dengue fever. Zika, though, was not new. The first identified case was in 1947 in monkeys, and the first human cases in 1952. But until 2007, only 14 cases were documented worldwide. However, in 2015, there was an increase in newborn infants presenting with microcephaly in Brazil, and this was traced back to an infection with the Zika virus. Now, microcephaly is a devastating condition resulting in seizures, feeding difficulties, and severe developmental delay. And through 2016, there was a 20-fold increase in the incidence of microcephaly. An estimated 4,000 babies in Brazil were affected. But interestingly, just as quickly as it came, it appeared to disappear. And there's been lots of speculation as to why this may be so. A scientist called Professor Neil Ferguson, who may well be familiar to many people now, and his modelling team from Imperial College London, writing in Science, was confident that the epidemic would be over within 2 years. He wrote, "Our analysis suggests that once the current epidemic is over, herd immunity will lead to a delay of at least a decade before the large epidemic may reoccur." In fact, within a year, the epidemic had all but disappeared. Herd immunity is still thought to be the major mechanism here. Zika, on the whole, causes a mild illness, and there is also possible cross-immunity between Zika and its cousin dengue fever. So with that in mind, when in January 2020, the WHO declared another viral outbreak, a public health emergency of international concern, this time to the novel SARS-CoV-2 virus, it was not perhaps surprising that paediatricians like myself were concerned. Now, I can trace the origins of this talk to April, when at the start of lockdown, Dr. Kathy Beardsall, pictured on the top left, who's a senior lecturer in paediatrics, and I were meant to supervise a placement on the neonatal intensive care unit for a couple of medical students, Charlotte Burren, bottom left, and Aisha Iqbal, top right. And like everything now, the placement actually occurred online, and we bounced various ideas around of projects we could do. Charlotte actually wrote an excellent piece on the dangers of children of prolonged school closure. And Aisha's project was focused on the potential effects COVID may have on the fetus. And it's interesting now, presenting this talk 8 months later, to see how this story has developed. And I'm delighted to say that Aisha's work was actually accepted as a publication last week in the journal Acta Pediatrica. And a lot of what I'm going to talk about is based on the sort of outline of this paper. Now, very early on in the pandemic, there was a paper investigating vertical transmission published in The Lancet back in March. It was a retrospective study of 9 women in Wuhan. Since then, I can't remember where I found this, but around, and it's probably now hit the 100,000 mark, 98,000 papers on COVID-19 have been published. And only about 500, though, are related to perinatal or neonatal issues. So, I think what I want to try and do in this talk is take a broad overview of the virus and the pandemic could affect the fetus. And this illustration, which Aisha created and is in the paper, shows how initially the immediate concern of viral infection to the mother and fetus is a worry, but it then relates to issues around pregnancy and maternal well-being from factors related to lockdown, social restriction, access to healthcare, etc. And this can all impact on maternal anxiety and stress, which in turn can affect fetal brain development. And it's these societal and psychological factors which Sarah will address in the second half of this talk. So I've divided the talk into 3 parts. So I'm going to talk about why this virus may make the fetus worried, and particularly review the global context and the effect women it may have living through a pandemic. And then Sarah will go on to talk about the Cocoa Pit study, which we have set up in Cambridge to look longitudinally at the effect of COVID on pregnancy, infancy, and parenting. So let's start with the most direct potential effect of the virus, and that is a direct viral infection on the developing fetus. And I'll firstly review, the theoretical reasons why a fetus should be worried of a new virus. I've already talked about Zika, but there are 5 other viruses which can cause serious disease from vertical infection from mother to fetus via the placenta. There are other congenital infections, but they're not viral, such as toxoplasma and listeria. But rubella, parvovirus, varicella, cytomegalovirus are all devastating conditions to the unborn child. There are some other viruses, mostly herpes, HIV, and hepatitis, which can result in serious illness by horizontal transmission at the time of birth. Now, some of these viruses are still present and still cause concern, but vaccination has made something like congenital rubella pretty rare in the 20th century, in the 21st century, but early in the 20th century, it was much more widespread. And just as a sort of sideline, I noticed that even Agatha Christie's book, The Mirror Cracked from Side to Side, the murder was all resulting from a mother who gave birth, or either gave birth or had a stillborn baby due to congenital rubella, and she never forgave the person who gave her rubella infection. And aside from direct viral infection, the mother becoming ill also has an impact on the fetus. So pneumonia is associated with increased hospitalization and death in pregnant women generally. The 1957 Asian flu pandemic resulted in a case fatality rate twice as high in pregnant women compared to non-pregnant women. Influenza is associated with stillbirth, preterm birth, and intrauterine growth retardation. And there is some limited data from the SARS and MERS outbreaks suggesting worse outcomes for mothers and their babies. But thankfully, those outbreaks were relatively small in number, so the numbers of women affected were also small. But I'm also going to just look at the developing fetus and why, in theory, the fetus should not be worried. As a neonatologist, I'm a baby doctor. I look after the newborn infant, but it's important to understand that in the womb, the fetus is a single unit alongside the placenta. And the placenta is a remarkable organ in that its unique architecture, it's able to access the maternal blood supply while protecting itself from blood-borne infection. The human placenta contacts maternal blood with these little intervillous blood spaces here, and you get these chorionic villi forming throughout gestation. So you've got this whole sort of pool where they're sort of soaking within the maternal bloodstream. And exchange of maternal blood and fetal compartment occurs across this villus surface through what's called the syncytiotrophoblasts. And we'll see that this multinucleate syncytium is a key physical barrier for the prevention of infection from pathogens. There's a sort of myth that mother is effectively immunocompromised in pregnancy, with the idea that it needs to prevent her immune system from rejecting the developing fetus, which is seen as a foreign body. This is in fact not the case, and the maternal immune system is actually uniquely designed the other way around to prevent the spread of pathogens to the relatively immunocompromised fetus. This slide on the left here shows some of the physical barriers and immune defenses in the feto-placental unit. And what we've done on the right here, this illustration has zoomed in on the developing placenta in the first trimester. And the invading cells, known as the cytotrophoblast, will go on to form this continuum called the syncytiotrophoblast. The word is derived from 4 Greek words together, which literally mean together of cells, nutrition, and bud. So it's a sort of bud which allows the sort of nutrition of the fetus to occur. And it's this joined up syncytial property which is so important, since maternal white blood cells, like any white blood cells, can migrate into tissues by squeezing in between cells. And if they were to reach the fetal side of the placenta, many foreign proteins would be recognized, theoretically triggering an immune reaction from the fetus. However, because the syncytium acts as a sort of giant cell, there are no gaps for immune cells to migrate through. On the maternal side, you get natural killer cells and macrophages, but not the CD4 plus T cells, which would cause a sort of immune reaction to the placenta and fetus. And one of the ways the placenta does this is by suppressing the expression of immune related genes, the HLA complex, HLA-B and A and B. And these genes normally express the MHC ligand, which is a major binding mechanism for T cells. So by decreasing the translation of these genes, the syncytiotrophoblast reduces the attack by T cells. So it both protects the fetus from the mother's immune system, but also protects the fetus from foreign pathogens. The effectiveness of the fetal and maternal defenses actually is highlighted how few viruses actually infect the fetus. This is a fantastic editorial from Nature in 2011, and it puts viral infections, particularly in the fetus, in some sort of context. So apparently there are 10 to the power of 31 viruses in total on the planet. 320,000 different viruses are thought to exist within the mammals. Around 200 viruses will cause human disease, but there are only around a dozen or so viruses which cause serious disease in the unborn baby. So it shows how effective actually the maternal immune system and the placenta itself is at protecting the fetus from viral infection. And just as a note, 10 to the 31 viruses, N on end, would stretch apparently for 100 million light years, according to Nature anyway. So one little postscript before we sort of say, oh, well, the fetus is going to be fine. And this is an interesting paper which looked at the effect of bacterial infection during pregnancy, a condition called chorioamnionitis, which sets off a whole immune cascade, which actually could make the fetus more susceptible to viruses, and particularly to SARS-CoV-2. Because it's well documented that the spike protein in the SARS virus will bind to the human ACE2 receptor. And in presence of chorioamnionitis, there's an upregulation of ACE2 expressing immune cells. And it's also perhaps even more concerning that these syncytiotrophoblastic cells also contain ACE2 receptors, providing in theory a gateway for the virus to enter the fetal circulation. Now, the virus is only, 10, 11 months old, but data has already sort of come in as to what is the impact in pregnancy. This is a study from the UK, which showed that in the first wave in the UK, looking at 427 pregnant women admitted to hospital with confirmed SARS-CoV-2 infection, and of which 262 gave birth. Interestingly, in this paper, 50% were from Black and Asian minority communities. 70% were overweight or obese. 40% were slightly older, 35. So similar sort of demographics that we've seen in the general population. And the maternal outcomes were similar to non-pregnant women of similar ages. Around 25% of babies were born preterm, with 32, nearly half of that number, due to maternal COVID-19 infection. So either going into preterm labour or the obstetricians expediting the delivery of the preterm baby because of maternal illness. Only 5%, however, did test positive for SARS-CoV-2, and only one infant was admitted to the neonatal intensive care unit. So within and that sort of represents the sort of pattern we saw at the Rosie, very few babies being admitted. In fact, we've had no babies with positive infection, a few suspected, to our unit. There have been a couple of meta-analyses now that a number of sort of case reports have been studied across the world. And again, ICU admissions and maternal death was comparable to those reported in non-pregnant women. So pregnant women do not seem, or their immune system does not seem to make them more susceptible than non-pregnant women of similar age. There was a high rate of cesarean sections, which was slightly, and I'll come back to this again, but later on, the guidelines and expert recommendations did recommend opting for vaginal delivery wherever possible, but it did seem that obstetricians did sort of favour in mums who were positive to opt for a surgical intervention instead of natural delivery. And again, there was a slightly higher number of preterm deliveries, either iatrogenically or potentially because the infection triggers preterm labour. Only 4% of neonates in this study tested positive for SARS-CoV-2, and most of the neonatal admissions were done as a precaution or to isolate newborns from their mothers to prevent horizontal transmission. That's something that I'll come on to again a bit later on. They reported very low fetal or neonatal morbidity or mortality. And then this recent meta-analysis looked at the 176 published cases of newborns who have tested positive from mothers who were positive in the last trimester. And it's thought that 2/3 of those were actually postnatally acquired. So only 30% thought to occur either in utero or during delivery. There was no evidence of infection in either the amniotic fluid or cord blood or breast milk. We still don't have enough reliable data, though, of what happens in the first and second trimester of pregnancy. If you think about it, the COVID generation, where most of them would have been conceived at the beginning of the year. So we still wait to see what mothers who have had early infection, what the outcome is for those babies. And one of the real challenges has been trying to ascertain what is true congenital or intrapartum cases from postpartum acquisition, with only a few definitive congenital infections reported, and a lot of uncertainty around, was this actually born around the time of delivery, or actually was the infection acquired in the sort of immediate day or so after delivery horizontally. So congenital infection does seem to be rare, but it's sometimes quite interesting to look in more depth at some individual case histories. And this was an interesting case from France, who reported a 23-year-old mother who was positive and unwell with COVID-19, who gave birth slightly prematurely at 35 plus 5 weeks to an infant who initially required some respiratory support, but at 3 days of age became more unwell, was irritable, wasn't feeding, and was hypertonic. The infant also tested positive for SARS-CoV-2 and had a high white cell count in the spinal fluid, although the virus test was negative. But the MRI they did at a week of age showed this sort of gliosis, sort of reaction within the white matter. And so it does suggest that, yes, the fetus and the newborn infant are unlikely to get disease or severe disease, but one should still remain alert to the possibility that a few of them may succumb and may have consequences, which, like in the adults, may go on for some time. So, like everyone else, the fetus probably should stay alert, if not worry too much. So the second part, though, is perhaps more relevant, and that's the effect on the fetus for the mother having to live in the pandemic. So what I want to do is look at how all the measures that occurred from April might have an effect on maternal well-being, and this is something which Sarah will explore more as she talks about the Cocoa Pit study. So much has happened this year. It's, I think, easy to forget what a dramatic moment it was when we were all told to stay back home back in April. And really nothing like this has happened in our lifetime. The nation almost sort of took a breath to sort of try and work out what actually was going on. This photograph was taken by my colleagues in the general pediatric department. And I think you can see on their faces, there's genuine anxiety as to what is about to unfold. So this time has been a time of huge personal and societal upheaval, with a loss of professional and personal support structures, as well as radical changes in the delivery of healthcare. In pregnancy, mothers were seen as moderate risk, and so were advised to stay home. And as has been well documented and reported, the virus is far from being a leveler in a society, but rather exposed the deep inequalities that we have between rich and poor. And again, people from poor or ethnic minority groups are affected disproportionately. And that would suggest worsening health outcomes for mother and baby. Pregnancy can be a trigger for domestic abuse, even in the absence of lockdown. And existing abuse may get worse either during pregnancy or after the child has given birth. Domestic abuse in pregnancy increases the risk of miscarriage, infection, premature birth, injury, or death to the baby. Rather shockingly, it was reported in the first 3 weeks of lockdown, 16 killings related to domestic abuse, and 40,000 calls made to the National Domestic Abuse Hotline in the first 3 months of lockdown, far more than one would expect in a similar time period. In May, a report from the Board of the Human Rights and Childbirth group provided some sobering accounts of human rights violations across the world. This report included reports of birth partners not being allowed to be present, even if national government advice was different. The requirement that pregnant women and families purchase PPE in order to enter the hospital, again disadvantaging those who couldn't afford it. Freedom of choice, which was seen as a fundamental right in childbirth, has been violated without any real evidence base. For example, women being required to have interventions in childbirth, such as epidurals to avoid emergency cesarean sections under general anaesthetic, the administration of intubating a patient given general anaesthetic is an aerosol generating procedure, so unless the staff are adequately protected is a risk. Women are subjected to forced inductions and cesarean sections. As I mentioned earlier, there's an increased rate of cesarean sections. So in Croatia, the head of Gynecology and Obstetrics Society announced that all pregnant women with COVID-19 should have a cesarean section and be separated from their newborns. Once the mother has given birth, there are also widespread reports of mother and baby being separated, again with no evidence base and against the WHO guidelines, which recommend skin-to-skin contact after birth, keeping mother and baby together, and encouraging mothers to breastfeed. So, for example, a report in Malta showed that women who were COVID-19 positive were quarantined from their babies for 14 days. In Romania, babies who were removed from their mothers regardless of the COVID-19 status, and there were reports of infants becoming infected with COVID-19 from healthcare staff, which is kind of counterproductive. Again, it's women from marginalised groups who will suffer disproportionately. In the UK, although not directly related to health, maternity care, but Black and Asian minorities make up the majority of healthcare providers who've died of COVID-19. In Hungary, practices around mandatory maternity clothing was applied in a discriminatory way against ethnic minority Roma women. And perhaps most horrifying was this report in Kenya of a woman at labour at home experienced severe bleeding, delayed travelling to a healthcare facility because of fears of police brutality during the overnight curfew, which was implemented as a result of COVID-19, and she bled to death. I'd like to think that in the Rosie in Cambridge, we have strived to do our best for families while maintaining the safety of our staff, particularly at the beginning when there was a lot of uncertainty. Partners have been allowed to attend deliveries throughout. There were early restrictions on partners attending antenatal appointments, but they've now been lifted. Mothers are not separated from their baby unless for medical reasons or admission to the neonatal unit is required. On the neonatal unit, there was a policy of restricted visiting for both parents, but now we are back to having open visiting 24 hours. Parents still have to wear masks, which does worry me, especially for our long-stay patients, as face recognition is actually important for infant emotional development. A little bit sort of sobering few slides. So it's not all bad news. I suspect there will be a little baby boom over the next few months as the number of lockdown babies will hopefully be born to happy families. So the effect on lockdown and the associated consequence has real potential to increase stress and anxiety in pregnant women. And this has a real direct effect on fetal brain development. And this goes to a subject called the developmental origins of health and disease, which is a broad concept suggesting that the fetus will respond to cues from its environment in utero to alter the trajectory of its development. And this programming may convey a benefit to the fetus during its life, but actually may lead to permanent alterations in structure and function of the organs, which may result in an increase in non-communicable diseases such as diabetes or heart disease. But also there's now interest in altering brain development, leading to an increase in mental health disorders later on in life. It's very much an emerging field, but evidence to date has shown that maternal depression during pregnancy has been reported to be associated with the development of depression in offspring. There's a Danish study looking at a large number of births showing that the death of a relative during the first trimester of pregnancy increased the risk of the male offspring developing schizophrenia later on in life. In utero exposure to maternal bereavement shows an increased likelihood of the offspring taking medication either for ADHD in childhood or also medication to treat anxiety or depression in adulthood. And interestingly, psychological stress induces changes to the vaginal microbiome, which in effect has an effect to colonize the fetal gut. And there's an interesting concept that changes in urovaginal infection during pregnancy could lead to alterations in the gut microbiome, which could potentially lead to the developmental autism spectrum disorder. I'm slightly sort of skeptical of that because just about everything in the world causes autism. But certainly the link between the gut microbiome and brain development is something of real interest. So I'm going to end my presentation with a slightly busy slide, and I hope the animation works. So you have a mum who is stressed, and this leads to a whole range of particularly hormonal reactions and also inflammatory reactions. And as I mentioned, changes in the birth microbiome. And this has the effect of directly on the placenta altering hormonal control. And if we work from the bottom upwards, the change in the birth canal microbiome can result in impaired programming of the gut-brain axis. Reduced uterine flow can result in impaired fetal growth. You also get impaired fetal growth from increased corticotrophin releasing hormone. Increased cortisol will disrupt the whole hypothalamic pituitary axis. And a whole number of these factors will influence directly brain maturation and neurogenesis. And there are lots of interesting both fetal and early neonatal MRI studies looking at maternal stress and structural changes in the newborn brain. And I alluded to the idea that possibly inflammation or some sort of antenatal stress can actually directly lead to, or is directly associated with, an increase in psychiatric disorders later on in life. So with that in context in mind, hopefully we can switch screens, and I'll hand over to Sarah for the second part of the talk.
Thanks, Topun. I will just share my screen. Can you just let me know you can see mine, Topun, before you mute? Does that look okay?
Yep, looks brilliant.
That's perfect, Sarah.
Thank you. Okay, so with everything that Topun has just talked about in mind, something that myself and Topun and our colleagues put together earlier in the spring this year was an online study called COCO-PIP, to look at how COVID-19 affects the context of pregnancy, infancy and parenting of people going through this period of life. So we began to talk about what we might ask in this period of time, being very concerned for new parents and expectant parents, and started those discussions in April. And actually, by the time we'd got ethics approval and got everything together, we started this study in July. So when I talk about this, I'm going to show you some of the early data that we've been looking at, and that is from the time frame of July to mid-November. So this is the data that we've collected across this time. But this is an open study, and we plan to continue to collect data going forward as we go through changes in lockdown. So it reflects some of the parents' early kind of concepts of how COVID first came into their lives, but we will also be recruiting new parents as we go forward. So as a plug, please do pass this on to anyone that you think might be interested in taking part in the study. So I just want to mention as well that my postdocs in the research group, Stacey and Ezra, have spent a huge amount of time of getting this ready, both in terms of trying to increase the diversity of the recruitment of who is kind of accessing and finding out about this study, and in putting together the framework of how to collect this data and start analysing it. So I have Ezra to thank for all of the slides you're about to see in terms of the data. So the design of this study, it's a mixed method study with both quantitative and qualitative data. It's online, as I said, and it accesses a range of questions in lots of different areas, including social, medical, financial support, COVID-related restrictions, parental mental health and stress, infant interactions and development. And it's targeted at those expecting a baby and those that have a new baby. So this is a questionnaire that's designed to be logic dependent and adaptive. It will show questions relevant to the parent's current situation. So that will be in 3 areas, first of all. So second and third trimester of pregnancy, if they have an infant aged 0 to 3 months, if they have an infant aged 3 to 6 months. And then for any of those parents that have taken part in more than one of those time points, they're eligible to be contacted to be followed up at 12 months as well. And these relate to the aims of the study, which I'm just going to describe on the next page. So the first aim we have in this study is to look at how access to social, medical and financial support amidst this pandemic is associated with parental stress, anxiety and depression. Aim 2 will be to look at COVID-19 related restrictions and how they moderate the depth and breadth of social interactions that young infants experience in the first 6 months of life. So as Topun was mentioning, in terms of the hospital care, where parents might have to wear masks if they have a baby that's staying in the hospital, we are also interested in just finding out the breadth and depth of those experiences that they're having in the home. So whether lockdowns affected the number of people they're interacting with, or maybe improve the interaction they're having with people because they're more present if they're working at home. It could go in lots of different directions, and so we want to explore this. And then aim 3 brings both of those data sets together to then think about whether parental mental health and social interaction experiences mediate the infant's physical, social and cognitive development over the first year of life, where we would look across those time points. So today, we've managed to put together some of the preliminary data to show in this talk. Just to note, though, this is confidential data. We've only looked at this ourselves for the first time in the last couple of weeks. And these are not to be shared from the recording or today, please, without contacting us. Thank you. So we're going to focus on talking to you about the completed antenatal surveys in the most part. I'll touch on a tiny bit to do with those that have completed something postnatally, but the majority are concerning the 386 parents that have completed this. So the survey can be completed by anybody, but so far I would say, as you can see from these numbers, mostly it's been completed by mothers. So 370 of these were birth mothers, 3 non-birth mothers, and then we have 3 who are fathers and several that haven't completed that we're unaware of. And if we look quickly at the mean parental age, this is sort of fairly average for the UK, with a normal distribution around 32 years. So we have a further to date of 2-3 weeks ago of 635 families that have also completed the survey postnatally that we'll be looking at in due course. So just to think about the area of residence, this online survey is not a national study. It could be accessed anywhere in the world. So although we've probably been advertising it in the UK most of all, during the first few months of collecting this data, as you can see here, the majority of these families are from the UK. It has been accessed by other countries, and that's sort of a talking point for us at the moment, actually, as to whether to just get this out to more countries, try and promote it being kind of disseminated through other users elsewhere, and see if there are any collaborators that want to look at data from their own country as it comes in. But just to say, within the UK, we strive to try and send this out to not just people in Cambridge that we might be connected to through the hospital or through our research group. And it's nice to see in this file that we put together just that there is quite a good spread across the UK. Because one of the sort of co-variables that we'll be interested in looking at is how some of these measures may change according to the period of lockdown you're in. And of course, we're now in a phase of local lockdown, so we'll have to monitor where these samples are being collected from. And as everyone likes to laugh about, there's not actually 2 or 3 families in the sea here. It's just not quite printed correctly in Wales, so that they weren't answering this from a boat, as my husband joked earlier. So let's have a look at the education level then. We've got this both for mothers and fathers. We'll start with the mothers. And so overall, there's about 70% of mothers that report having done an undergraduate or postgraduate degree. In fathers, that's about 50%. And just the reason I bring this up, I guess, is because this reflects a percentage that's actually different from the percentage of studies that we've completed in Cambridge so far. So in a previous study where we were recruiting families during pregnancy, usually they had about 80% that had these form of education. So we're hoping this reflects that we're accessing a more diverse population than those that would come into the previous work that we've done. So now I'm going to talk you through some of those questions that we've asked in the questionnaire, and we've picked out some that we've looked at in terms of some of these first questions for AIM 1. So the impact of COVID-19 on your kind of work home life. So this question asked, think about how COVID-19 has impacted your employment status, and respond to the following statements by checking the box. So here's the table here. And to talk you through these numbers, I'm just going to highlight the kind of trends that we can see that we'd like to follow up with interest. So we can see, obviously, as a lot of us know, many people were required to start working from home. Around half of the data collected from families reported that they started to do that at the start of COVID, and actually had kind of continued with the same trend into the last month that they collected data. So some of those families will have been from November, some may have been from earlier when they're reporting last month. Just be aware of that. There is a small proportion, but there is a proportion that obviously have had to then juggle childcare with work or homeschooling with work. That proportion may reflect the fact that some of these families are single families, so they didn't have this childcare homeschooling issue during COVID if they're expecting their first child. So we'll be exploring that question when we look at the data further. And then in terms of the change in job seeking or starting a new job or finding a new source of income, this has definitely increased, as you can see, although at the moment it's relatively low. So again, this is something for us to explore in terms of the economic impact as we continue through the pandemic, and may become more of an issue for families as they go forward through the winter. So the second question here is about how COVID has impacted their employment status. So in regard to that, I think there are two areas here that we picked up had an increase. So one is that the person filling in the questionnaire reported that they were worried about either their own or their partner's employment. So this was reported to be about 35% at the peak of COVID, but still remains at 20% in the last month, which again could reflect anywhere between August and November. Oh, my keys, 1 sec. And then just to say here as well, we just noted that we have about a third of the families are reporting that they're key essential workers. So this could be something that we explore in terms of the kind of context of work that they have and how this may relate to other factors. So in terms of their financial and housing situation, there is just under 20% of our families have talked about financial uncertainty. So it's not a big proportion yet. Again, something to look at over time and as we look across the time of data collection. But quite a significant proportion of these families have reported that they're separated from family and friends or loved ones that they used to visit regularly. So this certainly has been affected, as many of us know.
At this point, Dr. Sarah Lloyd Fox presented some unpublished data that was not shared in the recording.
Our original plan for 2020 may have evoked us to think about this online study, because we had planned to launch a perinatal imaging in partnership with families study, where we'd be doing a home-based longitudinal study following parents from antenatal to the first 5 months of life. And it was specifically actually within the context of early adversity and poverty and social interaction experiences. So for us, these two studies are just completely in synergy with each other in trying to understand how this new aspect of adversity in our lives may impact on the kind of well-being of the infant and family that surrounds them. Thanks so much for listening to us both, and welcome questions.
Thank you, Sarah and Topun, for that excellent dual presentation. Don't forget to join us next week for the last in our series for this term, when we welcome Dr. David Bellan from the Department of Psychology here at Cambridge University. David will speak to us about his research on social deprivation, coping and drugs, a bad cocktail in the COVID-19 era, sharing evidence with us from preclinical studies. We look forward to that talk, and we look forward to seeing you all next week. Thanks for joining us.